Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. Today, we are talking about two of my favorite topics, obviously all things cancer-related in oncology and breast cancer. But my second amazing interest and passion these days has been all around innovation and technology. So today, we are talking about just those two things, cutting-edge technology that will help breast surgeons achieve clear margins when removing tumors in the breast, and in turn, reducing or hoping to reduce the anxiety we as patients feel, wondering whether or not we need to go back in for another surgery. Did my surgeon get everything? Is everything all clear? And can I finally take that deep exhale? I am joined by Adrian Mendes and Dr. Allison DiPasquale. Adrian has over 25 years of experience in the high-tech industry and is the CEO of Perimeter Medical Imaging AI. The company's first-gen device, which was cleared by the FDA, uses optical coherence tomography, OCT. And this allows surgeons to see at the cellular level right in the OR room so they can make surgical decisions in real time about how much tissue to take or when it's too close. Dr. Allison DiPasquale is a leading-edge breast surgical oncologist based in Dallas, Texas. Her career is anchored in one mission: to accelerate the defeat of cancer by combining the most advanced technologies with exacting surgical skills and compassionate patient care. Today, she brings that expertise to bear at the forefront of breast cancer treatment. Welcome to the conversation.
Sure. Thanks, Laura. It's great to meet you, and thanks for having us on. So I'm Adrian Mendes. Perimeter Medical Imaging. It's a Toronto-based company. That's where we were founded about 10 years ago. I'm an engineer by education, and I'm the CEO of this company. I've joined about 2.5 years ago, and it's a very exciting time for us. You know, we're in this phase where we're bringing our technology out to more patients, to more surgeons, and we're in what I call the scaling part of the business right now. And I'm really excited to be here to tell you all about it.
Oh, can't wait to hear. And Dr. DiPasquale, tell me a little bit about your background.
Sure. So I am a breast surgeon at Medical City in Dallas, Texas. I run the oncology program here, and I am a self-proclaimed surgeon who loves technology. I think that the way that we do things better, the way that I can make my patients' surgery better, do it quicker, efficient, one and done, is to work with the industry. And so for me, I am a self-proclaimed technology brat. I love all technologies that are out there, and really focus and strive on how to help the really good ones make it to the next level so that all the patients can have the benefits of it.
Let's talk a little bit, and Dr. Pasquale, I want to start off with you too, just because, me as a patient and you as the oncologist kind of thinking about what happens when a patient gets diagnosed with breast cancer.
Knowledge is power. When a patient comes in, I want to get all of that information. Even though I am the surgeon and they usually come to me first, I always say I'm the quarterback. So I'm getting things going. And X, Y, and Z got all the exams going. So I don't just jump in and offer somebody in the first visit their surgical plan, because there's so many nuances that you touched on. So for me, it's about giving that patient as much information as they have before they go to surgery and giving them all the options. So things that weigh into that is genetic testing of the patient, so the patient's own blood, to make sure they don't need one surgery versus the other. The other is genomic testing of the tumor. So you mentioned you don't know if you think it's stage 1, or am I going to need chemo or not? And so we can actually test the genes of the tumor using MammaPrint, Oncotype, but MammaPrint's a great one that can tell us, you are actually this looks like it's a very slow growing tumor. It is a sheep, but sometimes it can be a wolf in a sheep's clothes, because it actually shows that it's a high risk tumor on the genes. So although I walk the patient through their pathology report, I do decoding the path report where we go through each thing, good, bad type of cancer, talking about don't worry, everything's actually kind of good nowadays with all the medicines we have. But then talking about the genomic testing so that they know and can be prepared for potentially needing things like IV medicine or just pills, or potentially not even needing the pills at all based off of their ultra low risk. So then I also get an MRI. An MRI also helps me take a look at the extent of disease, especially with the breast cancer that comes from the milk glands. that's called a lobular cancer. So that can be pretty insidious on the type of conventional imagings we have. So really giving them all of this stuff on the first visit, say, I'm going to get all these tests. We have a navigator that guides them down their journey. And then when they meet again with all of this information, that's where we can really hone in and make a cohesive plan based off of their MRI, their genetics, their genomics, and ultimately their personal choice. So that all weighs into kind of who wants to save the breast, who doesn't want to save the breast, and who should and who shouldn't. So when looking at all that, I think it's a multifactorial way of talking to a patient. But a lot of patients, if they don't have a gene mutation and they have one area of the tumor, or even two areas on an MRI that I can easily get out, they definitely can save their breast. And we talk about silver lining surgeries where we can even combine breast lifts, reductions. If the patient never wanted that, it's now covered by plastic surgery. So we do a lot of inventive silver lining surgeries to get the patient cancer-free, get them looking beautifully and home to their families, and try to do it all at once using technology in the OR.
When the company was founded, there was an understanding at the time that margins, the ability to detect them, to identify them, to look at them was an important problem to solve. Which I think now we're, especially on this podcast, we understand that it's a very important problem to solve to prevent, all the downstream effects of not getting that clean margin out on the first surgery. So when the company was founded, it was on the premise that this technology that we have, which I can go into in a moment, it gives the ability for the surgeon in real time in the operating room to look at things and see things that they weren't able to see before. Right. And with that information, then that surgeon can make decisions that can help them with their care for the patient right then and there, while the patient's still in the operating room with them. So this was so critical for us. And so a lot of engineering work had to go into, first of all, proving, is that possible? Can you actually see the things that we thought you could see? Is it usable across all the different types of situations that you might need it? There's different patients, there's different types of tissue. There's constraints in the operating room, right? The surgeon has a patient who's on the table. And so whatever you make for that surgeon from a product standpoint, technology standpoint, has to be easy to use, has to be quick, has to fit into the workflow. It can't disrupt. And the users, the surgeons are very busy people, and they've been trained to do a thing. And they're not focused on the technology, they're focused on the patient. So the more you can fit into there as seamlessly as possible, that's so important. So this is where we started from, saying, well, maybe there's a use case for this visualization technology that we have that would make it usable. And so we use something called OCT. Well, it's called optical coherence tomography. It's kind of like an ultrasound, which most people are familiar with, which is a technology that uses sound waves, and you shine them on a piece of tissue, they reflect back, and then you can create an image of whatever you see inside the patient on the screen, like all of us fat ultrasound at some point in time. However, with OCT, what we use is a light wave, infrared light wave versus sound waves, but it works in a very, very similar manner. The difference is that we can get very, very high resolution. Okay, so to get a little bit dorky, you can get down to 15 micron of resolution, right? There's 100 microns in a millimeter, right? So you get 15 of those.
And you're shining this on the extracted tumor or on the body still? Tell me a little bit more.
Yeah, no. So the surgeon will take the tissue out of the patient and then walk it over to the machine, which is a few steps away, and then scan the tissue over there. And then with that, they can see. So the nice thing about the technology is very high resolution, but it can penetrate a few millimeters into the tissue. So you don't just see the outside surface, you can see 2 or 3 millimeters in the tissue, which is important because your margins have to be clear down to those 2 millimeters of depth in most cases. So it turns out that the tech is really, really good for that type of application. So based off of that, okay, the core technology works. Now, how do we put this in a usable form that's quick enough, easy to use enough, can fit inside the operating room, inside the workflow at a cost that's effective, and all of those things to bring a tool from the lab bench into the real world application. So the company's been around for about 10 years now, and that's what we've been working on over that amount of time. Dr. DiPasquale can tell you a bit more about how it fits into her workflow. But from a technology standpoint, there's that imaging technology, OCT technology, And then upcoming in future versions of the product, an AI sort of an AI system that goes along with it that makes it even easier to use. Both of these two things together, in my mind, becomes the magic sort of combination of different types of technology moving along different sort of speeds, at different speeds along different tracks. But bringing them together now brings a very powerful tool that becomes even more usable to users that aren't used to seeing this or weren't trained in this back in medical school, right? And that's what's really exciting for me about where we are right now with the company.
Dr. Pasquale, without having access to this technology, how is it done today?
Well, there are many different ways that you can look at a margin. There are other technology companies that have tried in the past. Unfortunately, they're not very accurate. They're very cumbersome. They don't allow for the oncoplastic type of surgery that I do, the hidden scars, the areas that we operate. We don't operate right down over the top of the tumor anymore. We want to be far away because we want it to look beautiful. We want to hide the scars. So the way that you can do it without any technology is really you can take some shaved margins while you're in there and try to do frozen sections. However, the breast is primarily fatty replaced. And so when you do a frozen section, they actually freeze the tissue. So when you freeze it, you can actually freeze the fat cells away and it could be positive and it's really not, right? So a frozen section is not 100% accurate, especially in fatty breast tissue. It's probably even worse than getting a real assessment of it. So that's one way to do it. Some people universally just take shaves around the lumpectomy anyway and send those off as their extra buffer. There's lots of different ways to do it intraoperatively, but they're cumbersome. They take a lot of time. It's a pathologist sitting there and the patient's under anesthesia for that whole time. And so now it's just very easy. I go and do my operation. I do my lumpectomy. If I take shaves, I do that. I just hand them off the field. It takes 1 minute to scan per side, and I can see almost down to like a pathology level. I can see inside a duct, a circular duct, and is it full of something? Is it full of DCIS, right? Because that's the one the surgeons are always concerned about, the microscopic ghost, the stage 0 breast cancer, which is the best for the patient, but the hardest for the surgeon to get out because we can't see or feel it, right? So this technology actually allows me to see inside the duct the actual DCIS that's sitting in there. So it's actually just remarkable. You can scan through the whole specimen itself, and like Adrian had mentioned, you go down about 2 millimeters to make sure you got negative margins. Obviously, the invasive cancer you can see as well, but it's really, really helped me intraoperatively. That I promised that patient I'm going to get you home in time for dinner with your family, and we're going to get this out one and done. This is the closest technology that I have to be able to say that to the patient. And I was lucky enough to be on the clinical trial where we looked at the AI and chef's kiss. That's my favorite. That is really taking it to the next level. We all know everything is AI. This, again, is still looked at by a pathologist afterwards. So it's not taking the role over of a pathologist, but this is intraoperatively giving me that ability to say, wow, yes, this margin is positive, and this AI that has been trained so many times says this looks positive, not just my eyes as a surgeon trying to look and try to be a pathologist. This is trained AI. And so we're super excited about that coming out around the corner, and released our study, which was great.
Amazing. Adrian, can you tell me a little bit more about the role AI plays in all of this and what attracted you to join Perimeter?
One of the reasons I was attracted to come to Perimeter, I guess, a few years ago is because I spent the previous 6 or 7 years working in the AI industry. And I got very excited from the early days in 2016 when I really started getting into it. Of the progress AI was making in the world as a whole. In those early days, it was very much under the hood. It was like at the computer level, the data center level, computer chip software. And it's only recently that it's become sort of out on in the public domain where everyone could see it, right? The closest you ever got to it before was when Facebook or Netflix was giving you recommendations on things. But now we're seeing it in our entire life. So this was very exciting to me. Around that time when that was happening, I was introduced to Perimeter. So the trick or the thing that makes AI valuable for a company like us is the data, the training library that you have to train the AI to get smarter at what it does. And what Perimeter has is actually a very, very extensive library of images. We're imaging technology. So over the years, we've collected a ton of images, over 2 million images we have in our library. of breast tissue, right? And both healthy breast tissue, DCIS, invasive, all kinds of different types of tissue in the library. With that, you can train an algorithm to look and to recognize. So imagine you have a human being that has studied 2 million images of tissue and now is really, really good at detecting the difference between cancerous cells, healthy cells, different types of cells, and then being able to be in there with a surgeon in the operating room in real time telling you about that. That's the goal with any AI, really, right? But especially with this AI. So having a large library is very important. Having the ability to take those images and analyze them in real time in the operating room while the surgeon's right there is super important too. You can't have it sent away and then come back a week later, of course. And so this is where the real power of this thing exists. Now, the other nice thing about AI is when you release your generation 1 of the product, it's almost like the kind of tongue-in-cheek way I like to say it's the worst it'll ever be, right? Because that's always learning. Every new patient that goes through, every surgeon that's willing to contribute images into the library just becomes trained material for that AI to get smarter and smarter and smarter. So for me, that's very, very exciting. Some of the folks that were involved with the clinical study in the early days, like Dr. DiPasquale, were at the cutting edge of that, really the leading edge of that. And it's amazing to see where this will go, 10 years from now, even 2 years from now at the speed things are moving.
And so tell me a couple questions, just because this is where my creative brain goes. So I know we're talking about getting clear margins. Is there an application for this at all with regards to lymph nodes? Because I know right now, like when you're in the operating room, right, sometimes they'll do a test to see like if the nearby lymph nodes are infected or not. And so do you see applicability in that regard too?
I think yes. I think that's where, it's approved for all organ systems right now, for lots of other cancer organ systems, not just breast. It's just that breast is the one that has the most data on. But lymph nodes for sure, you can actually see just like you can, because a lymph node is usually primarily fat. But it's not FDA approved for that yet. Correct, Adrian?
Correct.
But yes, you're touching on where we need to go. Keep pushing the needle forward, because that's where we need to go.
So Laura, this is what's very exciting for us, within the company itself, right? We're not surgeons, we're not physicians. We partner up obviously with surgeons to make sure we're doing the right thing and having a roadmap in the right direction. But we're technologists. So we have a technology that we know can see microscopic level of detail. And if we get enough images, we can train an algorithm to recognize whatever we want it to recognize. But really the creativity of now what you use for the technology is going to come from people like, Dr. DiPasquale and the other surgeons. Not only in the discipline they work in, for example, breast cancer, but really across all kinds of other indications as well. So although we do have the biggest library right now within the breast image space, which is what then powered the trial and the next generation products coming along in that area. The current product we have on market right now is being used in multiple different types of tissue types, not just breast cancer. And all of this continues to make it more valuable that we can learn on all these indications and then, be able to grow this and bring this to so many more patients and surgeons out there.
Amazing. So I feel like we're talking about like this aha moment. This sounds amazing for patients. I have a couple of questions, if you don't mind, Adrian, taking me to. Like, do you have a story of like when you first were like behind this technology with Perimeter and you had to talk to like your first surgeon? How did you get them on board? Were there any roadblocks or questions? I'm always just asking myself too, like, how do you enter the market? And of course, no one wants to be the first. Or maybe you have the like, oh yes, choose me. I can't wait to be the first. So tell me a story where you had to, meet Dr. Pasquale or some other allies in your circle.
Yeah. So the way it works is it's really simple. It's simple, but it's a lot of work and it's hard. So you're, you're an engineer, you're a technologist, you've got a technology, you've spend time thinking about how it might work in different applications, and where the company is incubated, where Perimeter is incubated from the start, was actually within a different firm, or maybe a VC, an incubator, I guess the best way to describe it, that was working in breast cancer space already, right? So there was some thesis out there. There are surgeons like Dr. DiPasquale who are very interested in how they can improve their craft, right? And what are the tools that are out there? What are the cutting edge tools? Are they useful? Are they not useful? So if you can find those types of people, It's wonderful because they, in the early days, they really do expect it to be ugly and not really work very well and to be like kind of a pain in the ass to use. And there's a big question mark, like, would it work or not? But those for us are the best partners to work with, right? Because they understand the current state, and then they also understand the potential future. Now, we may never get there, right? Lots of technologies never get there. But if you can get there, then it's worth spending the effort on it, right? So in the early days, it was very much you have a camera, the OCT camera, and you've got some tissue. The camera has very high resolution, so it's very precise. So you have to be at the exact right focal distance. You have to have the exact right pressure on the tissue to keep it against it's like a photocopy, right? So against the glass, everything. And we had to learn every one of those steps. So at the end of it, we had a number of very wonderful surgeon partners with us that we could work with. We had pathologists that could help us correlate what we were seeing on our screens versus what they see under the microscope, right? Um, and it's really just you grind through every little problem. Okay, now how do we solve this problem? Okay, we now have the right amount of pressure you put the tissue under. Okay, how do we get the right focal length? Okay, now we have 1 millimeter, but the guidance says 2 millimeters. Now what do we do with the technology to get to 2 millimeters? Okay, now we can recognize DCIS. Well, what about other invasive? What about other types of cancers? Is it turning up different? Is it not? Um, so it's wonderful. And so you find these surgeons that are really open and willing to allow you to come into their operating room or willing to come back to the lab and work with us, when they're not in the operating room. And these partnerships are invaluable for us. Um, and I can't point to one because there's been so many of those all along the way from the early days, 10 plus years ago to even, just like a few months ago where we had a new surgeon picking it up for a brand new tissue type into the entire journey. But every time you find, at least from our standpoint, every time we find one of those surgeons that are willing to let us in to their house, so to speak, it's so exciting because we can then see how our little invention might work and how it might get better over time.
Yeah. No, I love that. And I love how you're framing that too. Even in my own work, especially with technology, where you have these moments of like, yes, I did it. And then you have like 100 new questions that like unraveled.
Yes.
And you're like, okay, one step forward, a million steps back, but like it was a good day. Right. And so really bringing it all together. I love that. And Dr. DiPasquale, how are you talking to your patients about this? Do they know that you're utilizing this technology? And have you actually seen this decrease the number of times people have to come back for additional surgeries?
Yeah, no, when I talk about the risks of surgery, I draw a picture. I have whiteboards everywhere. I'm old school. So we have these, they're beautiful whiteboards, but they're old school whiteboards. And I draw them a picture of exactly what we're going to do, how we're going to get their cancer out. How can I guarantee that I'm getting it all? Because that's their biggest question, right? Like, how do you know you got the right thing? And how do you know you got it all, right? And so I go through that with them. And then we talk about the risks of surgery. And one of the risks of surgery is a positive margin. And so the national average is about 25% chance of having a positive margin. You can ask any surgeon, they're going to say they're way less than that because we're surgeons, right? So that really is the data. 22% is on average, which is super high. Imagine all those patients that need to go back. So I tell them that, the ways I mitigate that is by using different localization techniques to help me get there. And then once I have it out, to try to take less normal tissue if we're not doing a large reduction or lift, and we just want to get the cancer out, is then utilizing this technology. So I explain the technology to them. I explain how it works and how I can decrease my positive margin rate. My personal rate is less than 7% because I've been working with technology all along. But I think that even 7% is too high because if you're in that 7%, that's 100% to you. Right. And so that is one of the things that, I just, kind of talk about the patients with and explain the technology. And especially when I was enrolling in the trial, I had people who were like, sometimes people who couldn't enroll because they had previous surgery, which was something we excluded. But they were like, oh man, I really wanted that. Can you please use it? And so obviously now being outside the trial, everyone's available to use it. And with the AI, it's just going to get better and better around the corner.
And so that brings me to my next question. Adrian, where are we in terms of like FDA approval, regulation for all of my listeners who are like, oh my God, I hope my surgeon is using this tomorrow when I have surgery? Where can they find this technology? Just give me like, where are we as of today?
Yeah. So we have one product on market right now, which has a general tissue indication, which was approved a few years ago by the FDA under a 510(k) clearance. Um, which allows surgeons, today this would be what Dr. DiPasquale is using, and we've got, a few dozen other surgeons around the country that are using it for breast cancer and other types of cancer. Okay, so that's available right now. If you go on our website, you can see a few places where, wherever we are. The trial that we keep referring to, so the difference between what we have on market today and what we're going to have on the market next year is really an AI, um, an AI algorithm that goes along with it, right? So think that same OCT imaging technology I described is what we have on market today. Now add an AI assistant, and this is what we're working with the FDA to get reviewed and onto market next year. What we did for this, just to give you a little bit of pathway through this, is we ran a very large clinical trial that wrapped up about a year ago, several hundred patients. And the way the trial was designed was very interesting. It looked at patients. So the surgeon performed all their normal standard of care for the breast cancer patient. And then at the very, very end, they opened up an envelope and it said either use the perimeter device or don't use a perimeter device. And so then they would use the perimeter device if that's what the envelope said. And they would take all that tissue that they had taken out of the patient and they would scan it with our machine. And then if they saw something there that caused them to make a clinical decision and take more tissue, they would do that. Okay, then all of that goes in our pathology, who's the final adjudicator of whether the margins are clean or not. And then they look and they say, okay, what was the situation after standard of care? And then what was the situation after the perimeter device? And the endpoint was to say, were more patients able to come out of their surgery with clean margins because of the perimeter device than would have been if the perimeter device wasn't used, which was the case. And so then we hit our endpoints, we submit our submission to the FDA, and that's been going through the review process right now. Our expectation is early next year, sort of first quarter-ish timeframe, we will get, it'll be finished the review. And then everything, assuming everything goes well, we should be able to get that on market early next year, which is wonderful. So then what ends up happening is for those surgeons that are breast surgeons using our product, it's a fairly easy upgrade path to move from the previous device over to the new device, which then gives them the AI assistant, which then helps them get faster in the operating room, have more confidence in the operating room, all the things that brings to them. And in addition to that, for those surgeons that are looking at the technology and saying, well, I would really love to have the AI assistant because that makes it easier for me to learn how to use this device. Well, now that's on market already. So that's kind of the flow that's, happening right now. So for those patients, I would recommend you talk to your doctor and find out what they know about us. We are in a handful. We're in the US really right now today. And then as time goes forward, we'll be more and more in more and more hospitals and with AI.
And Dr. DiPasquale, what would you tell your surgical colleagues who are hearing and listening to this podcast, but maybe not have had the opportunity to hear about this technology just yet? What would you share with them?
I would say that margins matter. There was discussion within the surgical, group in the field that, it's not a big deal. You just go back. That is a big deal. That somebody's got to take off work again. That someone whose family's worried. That's another anesthesia, another surgery. There's just a lot of burden onto the healthcare system and cost, plus the patient's emotional, social situation that they're going through. So what I would say is that margins matter. Your patients care about them. Please care about them. And the way that you can use technology to give them what they need, which is a negative margin, is to use this company. The AI is self-explanatory. It's super easy. You just say, hey, Celine, is it positive? Yes or no? And it tells you. So it's very intuitive. It's not spending extra time. It does not add extra time to the patient's surgery at all. And it's the right thing to do. And what I can say to the patients is ask your doctor. Ask your doctor, what technology are you using to ensure that my cancer is out? What technology are you using to employ the less is more theme that's in the cancer world? And have them sit down and go through that with you, because those are valid questions. You shouldn't just accept the first thing the surgeon says. Because you're going to be sleeping under anesthesia and you need to know everything, right? So just ask those questions for the patients out there. It's okay. The surgeons, I love those questions. I love sitting down for an hour and just chatting about everything that we can do and how we can do it better. and just also getting their comfort level back up, because they're going to be sleeping and they're in my hands. My job is to make sure they know what I'm doing and how I'm doing it accurately.
Well said. I love that. And if I heard you correct, you have an hour with your patients. Sign me up because I don't think that's the normal these days.
I do. We do spend a lot of time, especially the new patients, because there's just a lot to go through. And then the second, what all the tests that I ordered. So, and then we have navigators that are constantly texting the patient so they can reach me at any time. The navigators usually know the answers, but if they don't, weekend, when I'm operating, whenever. So it's good.
Yeah, no, that's wonderful. And like you started off the conversation, you really are that quarterback and that one really helping the patient through this journey. So to both of you, are there any things that we have not touched upon that you really want to get out there to our listeners?
Yeah, there's one thing I think that's very important. I talk a lot about the technology, um, and we're a small company. We are mostly a bunch of engineers and scientists. Um, we work very close with surgeons, but I think a part of that is we actually we're pretty humble about what we know and what we don't know. And so us being very close with our surgeons, so two things. One is because that's not our expert domain, being a surgeon, it means we are under no illusions that we know more than we actually know in that respect, right? So that's number one. And then number two, because we're a small company, we know that we have to learn faster, be more customer centric, because we can't, just sit back and sell the thing we've been selling for 50 years. So we're very, very much like that. So to the point of what Dr. DiPasquale said, with the surgeons out there, we try really hard to be very, very close to them and get their feedback into our product development, product roadmap. So that's a very important thing for us. Further to that, we talked about the reoperation rates within breast cancer, and they're very high across all different types of cancer. And Dr. DiPasquale shared hers, which is, far, far less than that national average. But also, Dr. DiPasquale is a fellowship trained surgeon in Dallas and has the opportunity to do many of these procedures every single day and is very, very highly trained, right? There are a lot of women around the country that don't have access to top surgeons like that in big city centers without having to spend a lot of money and take a lot of time to leave their home. Perhaps they've got young kids. It's hard for them to get to a city. And if they have to go back in for another operation, that's pretty tough too, right? Because they're now home back in their job or whatever, and they got to do that whole thing again. So one of the things that AI is good for, not just for the current surgeons, is that it gives the opportunity for these surgeons that are in more remote areas, perhaps, that don't do these types of procedures as frequently, who may not have the same reoperation rates as you'll see in a big city, to get closer and closer to that, which then, from a patient standpoint, because that's at the end of the day, the real customer, so to speak, of our technology, they can then get access in their small town, close to their home, where they're comfortable, they can be in their own bed at night, versus having to, travel long distance again to a big city. That quality of care brought out to those rural settings, for me, is extremely exciting. Because that way we can help the majority of the country that doesn't live actually in these massive cities.
I think the one thing for everybody out there is that we need to turn fear into hope. And the way that we do that is with good doctors and good industry and partnering together. So make sure, again, ask your doctor what they are doing to turn that fear into hope and giving you all that knowledge and confidence that when you go under, you'll come out and be cancer-free. I always tell my patient, welcome to your cancer-free day on their surgery day. That yes, there's may have roads ahead of them with extra treatment, but that is their official cancer-free day.
That's amazing. I had a very similar mindset actually going into my surgery. I was meditating a lot the night before, but waking up, they make you come in at 4:30 in the morning, 5 in the morning, right? You had to get there so early for all the pre-op stuff. But I just remember being no, I feel calm because today is the day that they're going to take the cancer out and I'm going to wake up less sick than I was. And just that mindset was despite the fear of not getting clear margins, but I was just today was the day, I know my eyes are going to look healthier when I wake up. And I just love that you said that to your patient. So thank you both for taking the time to be on Breast Cancer Conversations today. I know, as you're mentioning, it's really important to work with industry, to really work with the healthcare professionals. I'll also put a plug in for us as patient advocates and the nonprofit organizations doing the work with the patients that we serve. please keep survivingbreastcancer.org in mind as we provide 100% free virtual programs, over 400 programs virtually a year, to support the mental health and wellness of those diagnosed. So thank you for joining us today and have a beautiful afternoon.
Thank you, Laura.
Thank you.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.